Share. How? What'd you do differently? Took notes. Anybody else want to share their technique? Yeah? Oh yeah, the book has just got so much more information than it's just like distracts you. Unless it's just with the pictures, it's good. Anybody else? Yeah? You write things down more? What did you do? Yes, regular studying with anatomy really, really helps. Cramming is really hard with anatomy. I don't know why. I mean, I know people do it, but they don't end up being ready for any conceptual questions. They're only ready for memorization questions when you cram. So feel free to like share the love with other people about how you did it, because you're not actually competing. There's not like a certain number of A's that I'm going to give out in the class. I'd love to give A's to all of you. I mean, you'd have to like get them out of me, but I don't have a problem with giving them. Okay, so let's look. So this is sort of what we were doing last time. And we said that this was what root, by the way? That's the dorsal root. And then the dorsal root has what general functionality? Sensory. It is sensory, right? And then the sensory information goes through the spinal cord from the back side to the front side, right? Toward dorsal to ventral. And this is the ventral root, yes? And that is motor, okay? So now we're going to see that if you go out a little further, you're going to see that there's some branching coming off there. So now that's what we're going to add to it. We're going to add the branching that comes off, and then we'll talk about the rest of it. Okay, so adding a little bit more detail. Once you get them together, since the dorsal root is sensory and the ventral root is motor, and we all agree with that, right? Once you put them together, this region right here is called the spinal nerve. And since the dorsal and ventral roots are sensory and motor, then the spinal nerve must be what in function? Yes, it is mixed. All spinal nerves are mixed. And let me remind you what a spinal nerve is, related to the things that we did before. These are the 31 pairs of spinal nerves, right? We talked about their naming and numbering last time. And the spinal nerve actually leaves between the vertebra in the intervertebral foramina. That's where it actually leaves. And all spinal nerves are mixed in function, all of them. It's not like cranial nerves, in which some were sensory, some were motor, and most were both, right? Or mixed in function. Does that make sense? Okay, so all of these are going to be what you're seeing right here are the spinal nerves. So, but then the spinal nerve even branches further. You ready? So it is almost immediately going to branch into a little bitty branch that goes which way? Is that anterior or posterior? Posterior. And then a much bigger branch that goes anterior. Now, why the two different sizes in the branches? Well, once it comes together as a spinal nerve, the branches stay mixed in function. So they divide not based on what they're doing, but where they're going. Okay, so this one goes posterior to the spinal cord, and this one is responsible for sensory and motor innervation of everything posterior to the spinal cord. But can we agree that there's not a whole hell of a lot back there, right? There's like a little bit of musculature and not a whole lot of sensory capacity even. Like if somebody's touching you in the back, you can like, even if you have an itch on your own back, you're like, oh, I don't know where it is, right? It's like on my back, I'm pretty sure. But you don't know what kind of thing is touching you. You like don't have much sensation capacity. And there's not a whole lot of musculature back there compared to up here, right? So this posterior ramus, and ramus means branch, by the way, it's going to be much skinnier, and it's responsible for sensory and motor innervation of everything posterior to the spinal cord. And then this anterior ramus right here is responsible for sensory and motor innervation for everything anterior to the spinal cord, including your limbs, right? So it's going to be much bigger and chunkier, lots more fibers in it. Is that good? Okay, now this guy we're not going to talk about right now, but we will address him in the next set of notes. This is actually part not of the somatic nervous system, this is part of the autonomic nervous system, so it's not going to be part of the stories that we're telling today. So now, what I want to do is I want to go through a couple of examples of how you would talk about roots and rami. And so what I want to do is I want to follow through this whole pathway all the way a sensory information in and motor information out with these structures to show you how they're used. So here's what I want you to, first example, I have an itch on my back, okay, an itch on my back, and I reach around with my arm to scratch it, okay? So which of these structures am I going to start at if I have an itch on my back? Posterior ramus, right? Because that's both sensory and motor innervation of everything posterior to the spinal cord. You with me? Okay, posterior ramus, following it in. And then what is this structure right here? That's the spinal nerve. And then now how do I get that sensory information into the spinal cord? Dorsal root, right? And then it goes through the spinal cord from the dorsal side to the ventral side, right? And then it's going to go back out. What's this? Ventral root, yes. And then through what? Spinal nerve. And then which one of these rami? Anterior ramus, right? Because it's going to my arm, right? That makes sense? Okay, so let's do one more and then, okay, so here's the other one. Remember that patellar reflex that I showed you guys the last time? Okay, so the patellar reflex, I want to follow that one in here, okay? So the patellar reflex is going to be sent to the spinal cord via what first? Anterior ramus, okay? And then it's going to go spinal nerve, and then where? Dorsal root, yes, and then spinal cord, which direction first? Dorsal, then ventral root, yes. Spinal nerve, then anterior ramus. Does that make sense? Okay, so that's the anatomy that you're dealing with here. The only other thing that I want to tell you guys is that the last class started doing functionality when we were talking about this. So can you add to that the whole functionality that we talked about? Well, both examples that we were just giving were what kind of sensory and what kind of motor? Somatic sensory, right, and somatic motor, right? That wasn't the question that I asked, but they started giving me those words, right? So I was asking structures and they were giving me functions. We could actually say to put it together, and I'm not going to ask you to do this unless it was a bonus question. The somatic sensory information about an itch on the back would go through, right, the posterior ramus, yeah? Then it would go through the spinal nerve and then the dorsal root, then the dorsal side of the spinal cord, and then the motor response to itch with my arm, right, would go through the ventral root, the spinal nerve, and then that somatic motor response would go to skeletal muscle via the anterior ramus, right? So you can put it all together. It is one story. It's just a little complex to put it all together at one time. But it was a good question, so I thought it was worth referring to. Okay, everybody okay with that? All right, so now you can see that probably a really common mistake is that people use roots and rami interchangeably. And you can also see that that will be wrong. So be careful, be cautious about when you're using one versus the other. So I'm going to give you two choices, statement number 1 and statement number 2, and I want you to tell me which one is true. The dorsal and ventral roots are mixed in function, that's statement 1, or the dorsal and ventral rami are mixed in function, that's statement 2. Statement 2 is correct. That makes sense? Okay. All right, so now what we're going to do is we are going to come back to our idea of spinal nerves. And remember that the spinal nerves are once you come together here. But when people talk about spinal nerves, just so you know, most of the spinal nerve, most of the processes from it are going to go through the anterior ramus and not the posterior ramus, right? Isn't that where most of it's going to go? So when you look at these spinal nerves right here, what you're actually going to see is they generally just lop off the posterior rami, and you don't actually even learn any of the structures that are innervated by the posterior rami in this class. I mean, you could in other classes. What you're going to learn is this big wad of nerve that comes off of the anterior rami, right? Does that make sense? So this big wad of nerves that comes off of the anterior rami. And for instance, when you're looking at the spinal cord dissection in lab, if you looked at it like last week or this week, it's a posterior aspect spinal cord dissection, and we took off all of the musculature, and then we took off the spinous processes of the vertebra. So you're not even going to see any posterior rami. You're going to see just anterior rami, right, that are coming off of there. Okay, so now let's talk about what's going to happen with these anterior rami. So remember what we said last time. We said that the spinal nerves are labeled roughly for the vertebra that's around them where they're coming. But there's C1 through C8, right? There's a cervical spinal nerves, numbers 1 through 8. There's T1 through T12, thoracic spinal nerves 1 through 12. L1 through L5, lumbar spinal nerves. S1 through S5, and C0. Okay, so now what we're going to do is we're going to learn a little bit of the functionality of these regions, right? And you already know kind of it, but not detailed. Okay, so dorsal, okay, so what's going to happen is if you follow these out, the anterior rami of the spinal nerves tend to form little wads of nerves because there's a lot of stuff that's going anterior. And those little wads of nerves are called plexuses. I know you want it to be plexi, but it's not. Plexuses is what they're called, even though it sounds wrong. Okay, so this is a cervical plexus. Do you see that wad of nerves that's sort of coming out right there? Do you see it? And then there's another wad that's going to the arm. That's going to be the brachial plexus. We're going to look at them all in detail in just a second. The thoracic spinal nerves don't form a plexus because they just sort of run parallel to one another. Here's the lumbar plexus right there, right? And then here's the sacral plexus. Okay, so here's what we're going to do. We're going to learn important nerve or nerves out of each plexus, right? And then how to recognize when we're looking at one of the plexuses. Okay, so it's a little bit easy if you're looking here, but let's figure out in isolation how you would find a plexus. Here is an anterior view of the cervical plexus. Now, how the hell would you tell it's a cervical plexus? Yeah, it's the atlas and the axis. Don't forget that you know the skeletal system well enough to orient yourself. If you see the atlas and the axis, you are at the top part of the cervical vertebra, right? So even if these numbers aren't there, and they won't be, just so you know, the ones that come out about C1 through C4, this is going to form this wad right here of nerves, and this is called the cervical plexus. Here is what I won't do to you. I will not ask you to label individual nerves out of this plexus because first off, it's hard, and second, it's not going to look anything like that in an actual human. It's not like they all stay exactly where you want them to be. But you will know that if there's a big wad of nerves that are coming out C1 through C4, that's going to be the cervical plexus. Okay, now, as far as learning the functionality of the cervical plexus, you can see, by the way, these blue nerves are not actually in the cervical plexus. Those two are actually cranial nerves. They just sort of run by there. And then this one's actually part of the next plexus. Hold on just a second. Let me make this stop doing that. Okay, so these guys, now look at what they're doing. You've got your lesser occipital nerve, which is going to this region, your greater auricular nerve, which is going over here, transverse cervical nerve. So it's like neck stuff, kind of, right? With one exception. The most important, arguably, nerve that's coming out of this plexus is one that you do have to know individually, because it's the phrenic nerve, and there's a left one and a right one. Anybody know what the phrenic nerve innervates? Diaphragm, yes. And that's pretty damn important, right? It is also coming out from way up here, and it's sort of breaking the general rule that we said that stuff here innervates stuff here, right? And stuff here innervates stuff here. The phrenic nerve, and the motor innervation of the diaphragm comes way out up here, and it goes and innervates the diaphragm. You should be able to find it this week in lab. You don't find it back here, though. You find it from the diaphragm and follow it up, and you can find the left and right phrenic nerves. So that's the reason that if I have a spinal cord injury up here or even up here, I don't lose control of respiration completely because the innervation comes from all the way up here. So in order to have a spinal cord injury that kills you because you can't breathe or puts you on a permanent ventilator, let's look at the anatomy that shows us how far up the spinal cord you would actually have to damage it in order to lose phrenic nerve innervation of the diaphragm. So watch here. So here's the phrenic nerve. Please note that some of the fibers sometimes go through C5. Most of them go through C4. You following me? Okay. Here's some more. Some of them go through C3. Every once in a while, one or two of them will go through C2, but most of them go here. So how high would I have to damage the spinal cord in order to lose motor innervation of my diaphragm? Above C3. Some people still have a little bit of innervation there, but above C3 or above C2, and your diaphragm doesn't work any longer. That makes sense? And so you would not only be a quadriplegic, but you would be a quadriplegic who is also on a ventilator. Okay? Christopher Reeve, before he died, you know, you guys are so young, you probably don't remember him as Superman, but he was one of the original movie Superman, well, not the original, but the 80s movie Superman. He damaged between C3 and C4. So he still had partial innervation of the diaphragm. So he was on a ventilator sometimes and not other times. I mean, it's really exhausting because Your intercostal muscles don't work, so you can't help with ventilation, but his diaphragm was still partially functional. Is that okay? Okay, in addition to doing that, the phrenic nerve also has sensory function from the thoracic cavity as well. Not that you really care, but sensory function from the thoracic cavity. Okay, so now the hardest plexus for you guys is the one that you're going to have to spend some time on in lab. It's called the brachial plexus. And the reason it's hardest is because it's the one you have to know the most nerves out of. But I'm going to give you some pointers as to how to find those. Okay, so let's see. The brachial plexus, let's find it. So we need to figure out how you would figure out that you were in the brachial plexus. But you can do it by process of elimination. Because even if these numbers weren't here, as long as the person wasn't standing on their head, I just ran into the first rib, right? That means that that's T1, correct? Okay, so this is the lower cervical and the upper thoracic. Or you could do it by process of elimination. Like, obviously, that ain't the brachial plexus because that's the sacrum, right? Or this guy right here, which is coming out, there's no ribs, there's no atlas, there's no axis, and there's no sacrum. This is the lumbar plexus. So you can do it by process of elimination. So let's go back to that brachial plexus. Okay, so the brachial plexus comes out C5 through T1, and these are still anterior rami that you're talking about. And it's the one that's going to be hardest for you guys. When you look at it in the cadavers, what you're going to do is you're going to be looking at it in the armpit. So we dissect it out in the armpit. And you can see some muscles, so some nerves innervating muscles. So let me show you what you guys are going to do. So I'm going to narrow it down for you so that when you get into lab, you'll have an expectation and it'll make it a little easier. It's going to seem really unpleasant to learn at first. But it clarifies. If you give yourself 15, 20, 30 minutes or look at it 3 or 4 times, you'll start to get it. So do you see, for orienting, I'm going to scribble it up on the board too. Do you see this M? Do you see that M right there? Okay, so what I'm going to do is show you what that M is and what it has to do with anything. So this M allows you to orient where you are. So this would be the body, right? This would be in the armpit. This would be the radial side, and this would be the ulnar side. That makes sense? Okay. All right. So the M, the muscles of the M help you to orient yourself. This one right here is called the musculocutaneous nerve. But this one's even easier because that one is the middle of the M. And the middle of the M is the median nerve. Good? Okay. And then the one that's on this side is easy because that one is the ulnar nerve. Good? Okay, so that's 3. And then there's 2 more that we can knock out of the list. And the 2 more that we can knock out of the list are the ones that dive under the M. Do you see that? That dive under the M. So that guy that's going to dive under the M right here, this one, if I followed it enough, it would actually wrap around and come out this side. This is the radial nerve. Radial nerve, and it would come out on the radial side. So where you label it is up to you. Sometimes it's easier to see up here, and sometimes it's easier to follow it because it's going to end up on the radial side of the arm. So that's the radial nerve. And then there is a branch off of the radial nerve that just dives deep into the armpit, and this is the axillary nerve. It doesn't seem to go anywhere. It just comes off of the branch of the radial nerve, and then it dives deep and it stays there. But the radial, if you followed it, it would go down a little bit, and then you could see it diving under the bone, and it's going to come out on the other side. Okay, and then the other ones are not too bad because they're going to a totally different place. So if you start looking down here, let's find the M on this guy. It's a lot harder to find on a specimen. First thing I need to teach you is how do you tell the difference between an artery, a vein, and a nerve? Because you're about to be in the weeks of lab in which you're dealing with a whole bunch of long, skinny things, and you need to tell the difference between them. So the thing you do is you put your gloves on and you start to feel them because nerves are not hollow, right? And so you can feel a hollow something when you roll it through your fingers, right? Arteries and veins are hollow, but they're hollow differently. Arteries are thick-walled and really elastic, so it's hollow, but when you let it go, it's going to spring right back up. Veins are thin-walled and not very elastic, so if you squish it, you can tell it's hollow, but it's going to stay flat. Does that make sense? So the first thing is in this big wad that you've got right here, by the way, this is the axillary artery. You can kind of see that it's round in this picture. So you first find the nerves, right? Figure out which ones are nerves, or at least which ones aren't nerves. And then after you've done that, let's find the M. You ready? Okay, so find the M. So here we go. Ready? So I'm going to find the middle of the M, which is right here. That's the median nerve. You with me? Follow it up, and then follow it down, lateral. That's the musculocutaneous nerve. Good? Back to the M, follow it up, follow it down medially. That is the ulnar nerve. Do you see it? Okay, so now let's go behind it. Do you see this one behind it? That's the radial nerve. Good? And then the axillary nerve, you can't see that it branches off with the radial nerve, but it does, and it dives into the armpit, like I said. That make sense? Okay, now the other ones are not going to be very hard for you. Sometimes they're hard to see on the cadaver, but they're not hard to understand. The pectoral nerves, if you found them, they would be going anterior on the pecs. And then the thoracic nerves are not part of this whole mess because they go onto the body, right, instead of out into the arm, right? So that gets you most of them right there. And it just takes a little practice, but you'll be fine with them. Make sure that you use your hands. I don't know if any of you guys are those kinds of people who don't ever want to touch the cadavers, but those kinds of people don't tend to do very well in lab. I mean, there's always exceptions. There are always people who can just look from 10 feet away and get it, but not very many people. Okay, so 1, 2, 3, 4, 5, 6, 8. 8 nerves on that. Now, the other thing that you're going to do in lab is there is a table in which you take these nerves that you're learning and you figure out which muscles you already learned are innervated by these nerves, right? So you figure out which muscles are innervated by the radial nerve and the ulnar nerve, but only the muscles that you already learned, right? Now, just so you know, that column used to be part of the muscle lab, and I took it out because the muscle lab was intense enough. So now what I'm going to ask you to do is you are going to have to go back and figure out innervation of the muscles that you already learned. And it's blank, and you're going to have to do it on your own. But the lab aides have the key, lab instructors have the key, and you could fill it all out before you even went to lab if you just go through the PowerPoints that are already put up there for you for lab, or the lecture text. So you can go do that. Okay, so you have to know all the muscles from your lab list that are served by each nerve in that brachial plexus. Okay, now let's do the thoracic spinal nerves. So I'll show you where they are. Okay, so the thoracic spinal nerves right here, T1 through T12, they don't form a plexus, they just stay parallel to one another. And primarily what they are going to do is to give rise to the intercostal nerves that innervate the intercostal muscles. So that's not hard. Go ahead.
Isn't T1 part of the brachial plexus?
It's also part of the brachial plexus. It has fibers that go into the brachial plexus and fibers that go into the thoracic spinal nerves. Does that make sense? Okay. So, by the way, there's a little bit of variation as far as where people's fibers go. Like sometimes if you're having some nerve damage, because there's variation between people, it might be a C5, C6 damage that's causing that symptom, or it might be C6, C7, because some of the fibers go one way or the other through the holes, and there's just a little bit of variation. I mean, I know it's not going to be C1, right? But it could go through different places. Okay, so next two plexuses. Lumbar plexus. Find the lumbar plexus by just having no atlas, no axis, and no ribs, and no sacrum. Then you're in the lumbar plexus. Or, of course, if you have a big picture, you can see where it's coming from, the lumbar vertebra. And it's about L1 through L5. So the lumbar plexus, primarily what it does is it innervates the glutes, parts of them, and it innervates the anterior thigh, a little bit of your junk, but not much of it, and really not your lower leg. So it's going to really go this direction, okay? Glutes and the anterior thigh. So you can look at it, make sure that you can find it, And then the two nerves that you have to learn out of it are not hard. There's really only two nerves, and they are the femoral nerve. And the femoral nerve is super easy because it just goes anterior and just sort of splits out into a bunch of little bitty nerves that you don't have to know the name of. So femoral nerve is going to be right here on the anterior thigh. And then there's one that's medial to that that goes through the obturator foramen, and it's called the obturator nerve, right? And so those are the two that you have to learn from that plexus, and they're not hard at all. They're the two that are on the anterior side of the thigh. And then the last plexus that you're going to learn is the Sacral Plexus. And the Sacral Plexus, do you see? S1 through S4, most of the roots don't come out of S5. And the biggest nerve in the body is part of that plexus. It's called the sciatic nerve. If you're looking at the sacral plexus, you're going to be looking at a posterior view most of the time because this will come out of the sacrum. So the lumbar plexus comes out of the lumbar region and most of it goes anterior. Not all of it, but most of it goes anterior. But if you're looking at the sacral plexus, most of it is going to come out of the sacrum and then it's going to go backside, right? So you would be looking at a face-down cadaver to find that one. So, and this is the biggest nerve in the body called the sciatic nerve. And it will also have a couple of gluteal branches on it, superior and inferior gluteal. And then this is going to innervate the rest of the thigh and leg that you didn't get before, right? Including the entire lower leg. So the branches off of that one that you're going to be interested in is if you follow it down, you are going to find the superior and inferior gluteal nerve, and then the sciatic will branch into the tibial and the common fibular. So let's figure out where those should be with reference to one another. If I have a tibial and a fibular, which one's going to be where? Fibular is going to be more lateral, okay? And then the tibial. Now, if you have a common, I don't know if you've seen this before, but if you ever have a common anything, it means it's going to branch. So if I have a common carotid, it's going to branch into the internal and the external carotid. If I have a common fibular, this one's going to branch into a superficial fibular and a deep fibular, right? And you should be able to find those just sort of based on what the name says, right? So you are going to be responsible for the muscles that are served by these nerves, basically that table out of your lab, okay? You're going to fill it out and you're going to learn the same stuff for lecture. And then the only other muscle that is part of this, but you don't learn it in lab because it's really hard to dissect out. I can't seem to get it dissected out without destroying everything on the way, is this guy right here, also part of the sacral plexus. It's called the pudendal nerve. Pudendum is a Latin word for external genitalia, especially female external genitalia. It means shameful. It's your shameful nerve, although when they figured out it went to the penis, they also wanted to rename it awesome nerve. Okay, they're like, if it goes to the woman, it's shameful, but if it goes to the penis, it's the best nerve ever. So this is the pudendal nerve, which is responsible for sensory innervation of your genitalia. Without this nerve, none of us would be here, just so you know. So you might as well learn that that's part of the sacral plexus right there. Okay, so we will stop there because that's where the other class stopped, and I will let you guys go enjoy your Halloween. Be careful. Don't eat any razor blades. Don't get run over by drunk people.